Bismillahirrahmanirrahim. Hi everyone. Today we're going to talk about the TSH test, a very important test that you are probably going to order quite often in inpatient setting. The first video we're going to talk about the TSH regulation just really briefly, and then when to order a TSH test in the medical wards and some of the disorders associated with the thyroid dysfunction. And then we're going to talk about when TSH level can be misleading, and also we're going to talk about the important disorder, the sick thyroid syndrome, when you read to be cautious interpreting the results of the TSH. So let's get into it. Okay, so we will discuss the regulation of the TSH hormone really briefly. So first of all, at the axis, the hypothalamus pituitary thyroid axis, start with the hypothalamus secreting the TRH, or thyroid releasing hormone, which stimulates the secretion of the TSH by the pituitary gland, the anterior pituitary gland, and the TSH is the one that stimulates the synthesis and secretion of the T4 and T3 to get released into the circulation. Now this happens mostly by the unit called the thyroid follicle, which is basically formed by the follicular cell, and the colloid, which has mostly the thyroglobulin. So the follicular cell has a basal membrane or part, and the apical membrane. So basically the synthesis of the thyroid hormones start by the TSH, the thyroid stimulating hormone, activate the thyroid TSH receptor, or the thyroid stimulating hormone receptor, and that through the cyclic AMP will help into the synthesis and release of the thyroglobulin. And there is also the NIS, or the sodium iodide symporter, which helps transportation of the iodide into the follicular cell. So what happens is both the iodide, now we have the iodide in and we have the thyroglobulin in, these two will be excreted through the apical membrane into the colloid, and then through the iodination these two will combine, and then through coupling we get the thyroglobulin with the MIT, or the monoiodotyrosine, and or the TID, or the diiodotyrosine, and based on the combination of these two molecules, then we get the T3 and T4. This coupling is assisted by the TPO enzyme, and that's very important enzyme, which is the thyroid peroxidase enzyme. And antibodies, again, this enzyme is the one that we sent when we suspecting thyroid disorder, as we're going to talk about in another video. So at the end of the day, after the iodination and the coupling, then there's going to be a release of the T3 and T4 after that into the circulation. And then the T3 and T4 through specific enzymes called deiodinases. There's three of them. There's a deiodinase 1 found mainly in the thyroid and the liver and the kidney, and there is a deiodinase 2 also found in the thyroid, but also in the brain and in the fat tissue. And then there is a deiodinase 3, which basically inactivates T4 to reverse T3. So basically these iodinase enzymes are responsible for the activation and deactivation of the T3 and T4 peripherally. Now the TSH level really changed dynamically in response to alterations of the T3 and T4. It's very sensitive. As you know, we get this negative feedback through the hypothalamus pituitary thyroid axis. So these really enzymes, T3 and T4, they really can affect the level of the TSH really dramatically, and that's why if you have a normal TSH level, most of the time that means there's no thyroid dysfunction. There's some few exceptions, and we're going to talk about that when we talk about thyroid disorders, but usually normal TSH is reassuring that there is no problem with the thyroid function to the most part. Now, as most of the other hormones in our body, the TSH is actually released in a pulsatile manner. The highest level occurs at night, but because of its relatively long plasma half-life, like about 50 minutes, only one single measurement of the TSH is adequate to assess for its level. We don't need to check it in the morning specifically, or in the night, or a specific time during the day, which like some other hormones like cortisol, for example. So this is really helpful. And then there's some inhibitors for the secretion of TSH. We're all aware of the negative loop by the high TSH and T3 levels, and they suppress the TSH secretion, but also cytokines like interleukin 6, interleukin 1, TNF alpha, and INF beta or interferon beta. These are also can be inhibitors of TSH, and this can play some role in the sick euthyroid syndrome, as we're going to talk about later. And then some drugs also, like high doses of dopamine or steroids or amiodarone, also can inhibit the TSH level. So this is just kind of a brief overview of the TSH regulation. So when to order the TSH level in the hospital? As you know, thyroid has many functions. It really affects almost every single organ or tissue in the body. So you can imagine that they have a lot of symptoms and signs associated with their disorders, whether that be hyper or hypoactive thyroid dysfunction. So I'm just going to give you some few examples that we commonly encounter in the hospital setting. So maybe we'll talk about the cardiac issues first. Patient who present with cardiac symptom like shortness of breath, palpitation, chest pain, and syncope. For example, patient, they have like arrhythmia, specifically atrial fibrillation, which is probably the most common arrhythmia, and then persistent sinus tachycardia. You might need to check the TSH. This could be associated with both hypo and hyperthyroidism, but more commonly with hyperthyroidism. Treatment of thyrotoxic causes alone can convert the atrial fibrillation to normal sinus rhythm in about 50% of patients. So it really can affect the management of this patient a lot by treating their thyroid dysfunction. Also, a patient with abnormal blood pressure, hypertensive emergency or urgency, especially with wide pulse pressure, which can happen mostly with hyperthyroidism, but hypothyroidism also can affect the blood pressure, especially the diastolic blood pressure. Patient with new CHF or CHF exacerbations, especially if there is no clear cause. Most of the time, patient, ischemic heart disease is a common cause, or poor compliance or diet with medications or diet are more common causes of exacerbation, but sometimes a new onset of thyroid dysfunction can also precipitate heart failure in these patients, or even cause like new onset of high output cardiac failure in some patients. Systolic murmurs because of the hyperdynamic circulation, especially with hyperthyroidism, can also make you think of thyroid dysfunction. Of course, most of the time this happens with other symptoms, just because of maybe if you're suspecting like mild benign systolic murmur, you don't need to check TSH in these circumstances. Low voltage ECG can be associated with thyroid dysfunction. For example, hypothyroidism can be associated with pericardial effusion, and this can lead to low voltage ECG. Now, also CNS can be affected on musculoskeletal disorders. Patient with altered mental status, seizures, even coma, or any suspicion of pituitary or hypothalamic disease. These are sicker patients. Sometimes they might be even the first presentation in some cases, like thyrotoxic crisis or hypothyroid coma or myxedema coma. So this kind of extreme dysfunction, but they can happen. And then patient with some vague symptoms, just tiredness or weakness, especially in elderly. I would like really you to pay attention to that. Of course, hypothyroidism can give you the symptom, but sometimes even hyperthyroidism in elderly, which is called apathetic hyperthyroidism. Elderly are not able to fully show you the hyperactivity associated or sympathetic overflow associated with hyperthyroidism, but they might present with like vague symptoms. And either situation, it's going to be useful to check TSH to rule that out, because it can be easily treated. Any proximal weakness, also thyroid dysfunction, is in the differential diagnosis of that, especially if the patient has persistent hypokalemia, like in hyperthyroid hypokalemic paralysis, which can be similar to periodic paralysis of hypokalemia. Some GI issues, of course, a patient with persistent or intermittent diarrhea, with weight loss, especially if they have good appetite or failure to thrive, can be associated with hyperthyroidism. Sometimes hyperthyroidism is also associated with weight gain, usually not very severe, but substantial weight gain. Persistent constipation, with hypothyroidism. Some bone issues, patient having like low velocity fractures. Maybe if there is no obvious cause, you need to check TSH to rule out thyroid dysfunction in this patient too. Abnormal labs sometimes, severe iron deficiency anemia in menstruating women. Maybe they're having menorrhagia because of hypothyroidism. Macrocytosis. Hypothyroidism can also be associated with increased MCV in CBC test. Persistent hypokalemia, we talked about that. You're going to check for hyperthyroid, hypokalemic periodic paralysis. Severe hyponatremia, if you suspect it's IAD, we talked about that when we talked about hyponatremia. Some experts recommend checking TSH whenever you want to diagnose SIAD. So you have to rule out thyroid dysfunction before you make the full diagnosis of SIAD. But most of the time, like we talked in the video, it's actually associated with severe hypothyroidism to give you genuine hyponatremia in most cases. Hypoglycemia sometimes can be associated with hyperthyroidism, hypercalcemia as well. Rhabdomyolysis can be also associated with thyroid dysfunction, and also mild increase in AST and LT, but this usually happens with moderate or severe thyroid dysfunction.